Whenever we meet a patient with newly diagnosed kidney cancer that's metastatic in the clinic, the discussion's really quite long because there's a lot to talk about. We have immunotherapy, we have VEGF inhibitors. For me, in my practice, I tend to start with a combination of axitinib and pembrolizumab based on the 426 data. Also based on the lack of immune-related adverse events compared to, say, IPI and NIVO. IPI and NIVO had a relatively high rate of requiring high-dose steroids to mitigate autoimmune events. They were mitigated, they were controlled, it is manageable, but it's certainly a situation I prefer to avoid for my patients. So in looking at the data, I think we're seeing with time similar, if not improved outcomes with axitinib and pembrolizumab. We do look at risk group in these patients, favorable or poor intermediate. Certainly for poor and intermediate, combination Axi-Pembro is usually our go-to. Ipi-Nivo is reasonable in that setting as well. For favorable risk, it's tricky. I think a purist would go combination therapy for those patients with axitinib and pembro. The data for Ipi-Nivo don't hold in that population. Sunitinib actually does better in the favorable risk group. But could some patients get away with a little bit of treatment, a TKI, or could they be observed? I think we have data to support those approaches as well. So it's really individualized to sort of the patient, their values, their comorbidities, and their situation in the favorable risk group.